COVID-19. And Jing Sun is going to talk about association between immune dysfunction and post-SARS-CoV-2 vaccination breakthrough infections, retrospective cohort study from a U.S. national sample database. So is my next slide, please. So the upcoming talks, February 14th, we're going to have a report from the vaccine effectiveness domain team, Nasya Sadfer, Emily Ploff, and Melissa Endel. So this is the monthly Recover Long COVID project team updates. Then we're going to take a week off for President's Day, and presentation is still to be nailed down the week after that. And March 7th, outcomes of SARS-CoV-2 infection in patients with chronic liver disease and cirrhosis study, obviously using N3C data by Jing. Next slide, please. So I guess we're approaching, there are lots of ways, obviously, of defining COVID positive cases, but we're approaching, I guess, an unfortunate milestone of 4 million cases, but it's incredibly impressive that we have essentially a several years window of data for that many COVID patients with lots of controls, 11.2 million people. So next slide. Okay, so we're going to start with the first talk. So Amanda, begin.
Okay, what do you guys see?
The slide layout, not the president. There we go.
Good.
You see what you're supposed to see?
Yeah.
Yes.
Okay.
Good. Thanks. Before we get into Amanda and Jing's talks, I just wanted to let everyone know that both of these research projects are coming out of the immunosuppressed compromised clinical domain team at N3C, which is led by myself out of Virginia Commonwealth University as the lead informatician, and Dr. Reena Patel out of the University of Washington, who's the clinical lead for the team. Next slide. So Amanda is coming from the solid organ transplant subdomain led by Dr. Roslyn Mannon, and Jing is part of the HIV subdomain team, which is also led by Dr. Reena Patel. Next slide. And I believe you already got an introduction to both of our speakers. So Amanda will be talking about major adverse renal or cardiac events in solid organ transplant recipients, and Jing's going to talk about her work in looking at COVID-19 vaccination breakthrough infections. So Amanda, I'll hand it off to you.
Great. Thanks, Amy. Thanks for the introduction. So I'll be talking today about our recent publication in the American Journal of Transplantation, a paper looking at sex and organ-specific risk of major adverse kidney or heart complications after COVID-19 in a population of patients who have solid organ transplantation. So solid organ transplant, or SOT, numbers in the United States are increasing over time. And you can see that that's true for all organ types, but particularly so for kidney transplant numbers, which have been skyrocketing. Due to the risk of rejection, solid organ transplant recipients require immunosuppression. They're organ-specific regimens, but generally this is triple immunosuppression consisting of prednisone, tacrolimus, and mycophenolate mofetil. Solid organ transplant recipients experience an increased risk of death due to cardiovascular disease, malignancy, and infection. And actually, the risk of cardiovascular mortality in patients who have solid organ transplant ranges from about 20 to 50 times higher than age, sex, and race-matched population controls. The 10-year patient survival rate after a deceased donor kidney transplant is about 67%, and that's higher than it is for all other organ types. Solid organ transplant patients with COVID-19 are at higher risk than the general population. Early on in the pandemic, the 28-day case fatality rate for someone with a solid organ transplant was about 20%, compared to about 1% in the general population. And although survival rates have improved over time with the pandemic, as we've had access to more better therapeutics and a better understanding of the condition, there remains a significant disparity in outcomes between solid organ transplant patients and the general population. Most earlier studies have been small-scale, single-center analyses. Both solid organ transplant and COVID-19 independently increase the risk of cardiovascular disease, and the risk of MACE, defined as major adverse cardiac events, or MARS, major adverse renal or cardiac events, in solid organ transplant recipients with COVID-19, at least at the time of this paper, was unknown, as was the impact of a specific allograft type on this, or really any outcome. In the general population, male sex is strongly associated with mortality from COVID-19, about 1.5 to 2-fold higher risk of mortality if you get COVID-19 and you're a man compared to being a woman. Whether male sex is a risk for solid organ transplant patients with COVID-19 is unknown. There was a meta-analysis of 74 SOT studies, including about 5,500 patients. And in that study, in that meta-analysis, sex was actually not associated with risk of death in COVID-19. However, this meta-analysis consisted of only kidney transplant recipients. And it wasn't true if this study represented a true mitigation of risk associated with sex or reflected just the small sample size of the individual studies included. The relative risk of organ transplant type with adverse outcomes after COVID-19 and how sex may modify this risk was also unknown. Therefore, in the largest study of SOT recipients with COVID-19 to date, we aim to explore, number one, the association between age and sex with COVID-19 risk in those with solid organ transplant, and secondly, the COVID-19 risk in solid organ transplant patients based on organ type. This was a retrospective cohort study of adult SOT patients in the United States with at least one positive test for COVID-19 from January 1st, 2020 to June 21st, 2021, and data was extracted from release 34. SOT patients were defined as having kidney, liver, lung, or heart organ transplantation. And as a comparator group, we examined all adult non-SOT patients captured in the N3C with a positive COVID test over the same time period. The primary exposure was sex age strata, so female versus male sex for each of those 18 to 45 years of age, 46 to 65 years of age, and greater than 65 years of age, for a total of 6 sex age strata categories. And our reference group was young males aged 18 to 45 years of age. For our secondary analysis, our secondary exposure was transplant allograft type, so kidney, liver, lung, or heart. And in the secondary analysis, we excluded any patients with multiple allograft types. Our primary outcome was MARS in the 90 days post-COVID-19 diagnosis. And we used a fairly standard definition here, defining MARS as the composite of AKI with or without dialysis, an acute MI, angina, stent occlusion or thrombosis, stroke, a TIA, congestive heart failure, or death from any cause. Our secondary outcomes included individual components of MARS, including MACE, AKI, and death from any cause, again in the 90 days after COVID-19 diagnosis. And we also looked at COVID severity defined as need for hospitalization. In our organ-specific secondary analysis, we also included the outcome of allograft rejection. For our primary analysis, the association between each sex age strata, again relative to the young male cohort, the younger males, and MARS was evaluated using multivariable Cox proportional hazard models separately in those with and without a solid organ transplant. And we adjusted for the covariates shown here. In our secondary analyses, we used multivariable Cox proportional hazard models to examine the adjusted hazard for each sex age strata separately on the secondary outcomes, MACE, AKI, organ rejection, and mortality. We used multivariable logistic regression to determine the association between these sex age strata and the binary outcome of requiring hospitalization or not after COVID-19 diagnosis. Analyses were then repeated for the non-SOT comparator group, of course, not including the outcome of organ rejection. Finally, for our secondary analysis, we meta-analyzed the relative risk of each primary and secondary outcome in the 90 days after COVID-19 diagnosis by allograft type relative to number one, those without a solid organ transplant, two, those with a kidney transplant. This was to allow us to examine the outcome of organ rejection. And then finally, in females versus males. We used random effects meta-regression with aggregate level data for each organ type, and heterogeneity between organ type outcomes was assessed using Higgins I-squared and the chi-square test of heterogeneity. So over the study cohort, we had over 1.9 million patients who tested positive for COVID-19. 13,000 of those had a solid organ transplant. When we excluded patients who had COVID and then subsequently were transplanted, we were left, and those missing gender, we were left with a final study cohort for our primary analysis of 10,987 solid organ transplant recipients with COVID and nearly 1.9 million non-SOT patients for our comparator group. In our secondary analysis, where we excluded patients who had multiple transplants, we were left with these final organ-specific cohorts. 90-day MARS risk, 90-day MARS occurred in 36.4% of patients who had a transplant and only 4.8% of patients who did not have a transplant. And as you can imagine, this was highly statistically significantly different. Looking at this with a little bit more granularity, so the outcome of 90-day MARS after a diagnosis of COVID-19 in those with solid organ transplant, so the blue bars, versus those without a solid organ transplant, the orange bars, stratified by age and sex. What you can appreciate here is that there's clearly an increased risk of MARS in patients who had a transplant versus those who did not. In addition, there was a greater relative increase in MARS risk with advancing age in those who did not have a transplant compared to those who had a transplant. And then finally, there was a greater relative increased risk in males versus females in the non-SOT cohort compared with the SOT cohort. You can see that best in the younger age group, whereby females and males had fairly similar risk of MARS. Males were a little bit higher risk, but for young males, the risk of developing MARS after COVID-19 was a little bit more than double that in young females. So MARS risk with COVID-19 is less impacted by sex and age in SOT than in non-SOT. When we looked at the adjusted risk of older age, so an age greater than 65 relative to those 18 to 45 years of age, the adjusted hazard for MARS in the 90 days after COVID-19 diagnosis was 1.55 in our SOT cohort and 10.08 in our non-SOT cohort. Likewise, the risk of female versus male sex was associated with an adjusted hazard ratio of 0.89 in solid organ transplant patients versus 0.61 in the non-SOT cohort. So our primary analysis is shown here. It's a little bit complicated, but what we're looking at here is the adjusted age, sex, strata risk in those with a solid organ transplant and those without a solid organ transplant for the outcome of MARS after developing COVID-19. And what you can see is that in the SOT cohort, there's really an attenuation of that risk. So there's not a big difference between males and females in any one age strata. And then also there's kind of a very minimal increased risk of developing MARS as you get older. Conversely, in the non-SOT cohort, what you see is that females in every age strata are lower risk than males, and there's more of an exaggerated increase in the risk of MARS as you get older. Looking at this another way, if you look at the relative reduction in MARS risk in females versus males, in those, again, with solid organ transplant versus those without, you see that, yeah, females are a little bit lower risk. Their risk is about 5.4 to 10.5% lower if you have a transplant, but that's compared to a 27.5% to 53.8% lower risk if you don't have a transplant and you're a woman compared to being a male. So there are large sex-based differences in COVID risk in the general population, and these appear to be very attenuated in the solid organ transplant population. So this is just building on that a little bit more. What this is looking at is hazard ratio in females versus males, with the reference group being age specific. So the risk of females versus males who are 18 to 45 years of age, 45 to 65 years of age, and so forth, in those with a transplant and those without a transplant. And what you can appreciate is that, yes, if you have a transplant, it looks like there's a trend towards being lower risk if you're a female compared to being a male, but females are not significantly lower risk. And if you don't have a transplant, there's a very exaggerated decrease in your risk if you're a female compared to being a male. Of course, the solid organ transplant population is a little bit smaller, so the confidence intervals are wide, but even if we had tight confidence intervals here, you can see that the point estimate is really not as low as it is in the non-SOT cohort. Building on this a little bit more, this is looking at our primary and secondary outcomes. Again, the hazard ratio in females versus males, this is all ages, and these are, again, adjusted models. So what you see is for all ages, MARS risk is a little bit lower in females versus males if you have a transplant. Mortality risk, same thing, a little bit lower in females versus males, and maybe a trend towards lower risk for MACE and AKI, and really no difference in COVID severity, again, defined as need for hospitalization. This is in comparison to the non-SOT cohort, where every single outcome is dramatically lower in females compared with males. And again, of course, the confidence intervals are a little bit wider in the SOT cohort, which is not surprising. But again, those point estimates are not as low as they are in the non-SOT cohort. So it really does look like there's an attenuation of risk. So in this study, in this slide, this is sort of the main messaging of the paper. So this is looking at the same thing I just showed you, but now adding age and sex strata. So this is the non-SOT cohort, again, primary outcome and all of our secondary outcomes. And what we see here is that in every single setting, males are higher risk than females, except for in the setting of COVID-19 severity amongst young 18 to 45-year-olds. Otherwise, in every scenario, at every age group, males are dramatically higher risk than females, and the risk clearly increases as you get older. So if you look at mortality, for example, the hazard ratio of a male more than 65 years of age dying after COVID-19 is 17.38, and that's compared to a young male. It would be even higher if we used a reference category of females 18 to 45 years of age. So this is the non-SOT cohort. If we compare this to the SOT cohort, I think this is really tells the story nicely. So what you see in the SOT cohort is really there's no difference for any one outcome between males and females. For, again, our primary or any of our secondary outcomes, there's no difference between males and females in any one age strata. And really, although there is perhaps a slight increase in your risk as you get older, it's completely attenuated compared to in the non-SOT cohort. So I think this really is an interesting slide. I just want to take a minute. I think this is such an amazing slide. So we're going to change gears a little bit and now talk about the organ-specific risk. So this is a meta-analysis of our specific organ types, kidney, liver, lung, and heart, looking at risk of MARS, our primary outcome, and then all of our secondary outcomes. And this is looking at the risk relative to those who don't have a transplant. What you can see are two main things. Firstly, the relative risk in any one organ type, kidney, liver, lung, or heart, is about 3 to 10 times higher than in the non-SOT cohort for all outcomes. Secondly, you can appreciate significant heterogeneity between organ types for all outcomes except for death. So what we're looking at here is this p-value is highly statistically significant, and this I-squared value is very high as well. So this is telling us that compared to the non-SOT control group, there's significant differences in the risk of each of these outcomes, again, except for death, where there's very low heterogeneity. So this is taking the same analysis, but now we're using kidney transplant as our reference group. The reason we did this was so that we could also examine the risk of organ rejection. So what you can appreciate here is that, again, not surprisingly, because we're using the exact same analysis, there's no difference in risk of death by organ type. So that, again, no significant heterogeneity in the risk of dying, depending on what organ type you have. What we can appreciate is that kidney and heart transplants were at the highest risk for MARS, MACE, and hospitalization. Liver transplant was the lowest risk for all outcomes, and lung and heart transplant recipients were at the highest risk for organ rejection. And again, this is the first time that this was shown. Finally, we meta-analyzed the risk, the sex-based risk by organ type. So this is looking at the hazard ratio in females versus males in those who have a kidney transplant, liver, lung, or heart transplant for each of the primary and secondary outcomes. What you can see here is that there's really no significant heterogeneity for any outcome. The greatest difference is in death, but again, that p-value is not quite statistically significant. So this is telling us that although there may be differences in risk by sex, it's similar between the organ groups. Females trended towards being slightly lower risk for all outcomes except hospitalization and rejection. And they were significantly lower when we looked at the kidney transplant alone population, but not for the other organ types. So this is the largest study to examine COVID-19 risk in solid organ transplant, the first to examine sex-based risk, and the first to examine organ-specific outcomes. We showed that all organ transplant types had worse COVID-19 outcomes than the non-SOT general population comparators. We showed higher risk of MARS, MACE, and hospitalization in kidney and heart transplant recipients, and a higher risk of organ rejection in heart and lung transplant recipients. Females were lower risk than males overall, again, not in our age stratified analysis, but females overall were lower risk than males for MARS, MACE, death, and AKI if they had a kidney transplant. However, there were no sex-based differences for any other organ type and no difference in hospitalization or rejection rates. So in non-SOT, males have a significantly higher COVID-19 mortality than females. My hypothesis is that this relates to inflammaging, which is defined as a decline in adaptive immunity and a dysregulated activation of the innate immune system with advancing age. Although this happens in males and females, it is much more prominent in males, and it has been associated with an increased risk of cytokine storm, and again, my hypothesis, thereby COVID-19 related death. We demonstrate that like in non-SOT, SOT males with COVID-19 do have an increased risk of MARS compared with females, albeit to a much lesser degree than in the general population. So an 11% reduction in MARS risk in females versus males if you have a transplant versus a 39% reduction if you don't have a transplant. Maintenance immunosuppression is a risk for infection in all SOT patients, but may differentially impact males and females with COVID. Females have greater baseline immunity than males, and therefore immunosuppression may mitigate their relative benefit versus males when infected with SARS-CoV-2. In addition, there may be a paradoxical benefit with immunosuppression, reducing that exaggerated and often fatal immune reaction to COVID-19 that disproportionately impacts older males. And that's what we might be seeing with the benefit that is observed with Decadron. So just looking at this a little bit, another way, just to hopefully make it clear, if we look at the sex-based risk from COVID-19 in the non-SOT versus SOT populations, in the non-SOT general population, women generally seem to have a better overall response to COVID-19, perhaps due to increased viral clearance and the increased risk that males experience with cytokine storm. However, in the immunosuppressed SOT population, the immunosuppression reduces the viral clearance that women, the preferential viral clearance that's seen in women, but it also attenuates that increased cytokine storm seen in males, thereby sort of evening the playing field. In addition, it's known that in the general population, women generally are more compliant with behavioral precautions, better hand hygiene, social distancing adherence, and masking. Whereas in the solid organ transplant population and in immunosuppressed populations in general, that difference is fairly similar between behavior is fairly similar between men and women. So in non-SOT, sex differences were most pronounced in the youngest age strata, followed by mid-age, and finally by the oldest age group. On the contrary, age did not impact observed sex differences in those with SOT. These findings are important as they provide a better understanding of the pathophysiology driving COVID risk. For example, are sex hormones playing a role? This study has limitations. It was a retrospective analysis, which comes with its inherent limitations regarding miscoding and misclassification. We didn't have access to community-based health records or biomarker testing, and importantly, no access to measured sex hormones. In terms of future directions, we proposed an analysis of sex-based risk of adverse outcomes following COVID-19 infection in those on hormone replacement therapy, again, in SOT and non-SOT patients. And in addition, we're working on an analysis of outcomes in SOT with breakthrough COVID-19 infection following vaccination relative to a non-SOT control group, building on the work that Jing will be presenting in the next talk. So in conclusion, SOT with COVID-19 are at increased risk of MARS and other adverse outcomes relative to non-SOT. There's a sex-based risk of all outcomes, but it's quite attenuated in the SOT population. Significant heterogeneity exists in the risk of COVID outcomes by transplant allograft type, with heart and kidney recipients being the highest risk. And this is the largest COVID-19 SOT cohort to date, and the first time sex age stratified analyses have been explored in those with and without SOT. So I'd just like to take a moment to acknowledge and thank Dr. Mannon. I am so grateful to be part of this team and for the invite to be part of the work done here. I'd like to thank Amy and the informaticists and analysts in our group and the clinical team who've provided input to this paper. Really, the entire ISC team has been remarkable, and the N3C in general. And with that, I'd be happy to take any questions or discussion.
Thank you. That was really a great talk, very, very clear and compelling. So we've got a couple of questions in the Q&A. The second one, Reena Patel, Amanda, great job with this analysis and presentation. Another kudos to our ISC domain team. Do you think there's any driving force in who gets selected for SOT receipt that might wipe out the sex differences in COVID that are so dramatic in the non-SOT group?
So great question, Reena. And, you know, there's a lot of, I do a lot of research in sex and gender in solid organ transplant. And we know that comorbidity burden is distributed differentially by sex. So men have a much higher risk of a lot of comorbidities that would put them at higher risk for things like MARS, acute kidney injury after diagnosis of COVID. But we adjusted for all of those factors in our analysis. And so could there be something playing a role there? Maybe, but we did try and adjust for those factors, given the fact that comorbidity distribution is differs in the non-SOT group and then in the SOT group.
Cool. And Thomas O'Brien says, this may be a minor point, but why did you select the youngest men rather than the youngest woman as the referent? Did you hypothesize the rates would actually be higher in the younger women?
Honestly, in hindsight, I don't know why I did that. I feel like I would have done it the other way if I had seen the results, and I think I should have done it the other way, but I don't know why I did it that way. Yeah. I think just because, honestly, I think the true answer, rightly or wrongly, is because men are always the reference group in every analysis, which maybe is not appropriate, but I think that's why I did it. I kind of fell into conformity.
And Jared Enzalone says, I think you may have a unique insight as a Canadian investigator. Do you think these findings are applicable outside U.S. academic health centers beyond just the community limitations you mentioned?
That's a really good question, Jared, and we should have discussed this so we could have planted the question beforehand. But I would say that I think that we know that there are differences in outcomes after solid organ transplant in the United States that are different from other centers. So higher risk of mortality, for example, in the United States compared to Canada, and higher COVID mortality as well. So I suspect that the sex-based differences probably would be preserved no matter where we looked, but there are factors that differ between the United States and other centers that I think are worth investigating. So it's a really good point.
So I have a question of my own, which involves data linkage. So as you know, this is a big thing at N3C, is linking external data sources through privacy preserving data linkage. And it would seem that this would be a really ideal case. If you thought about what data you might want to link and where it might come from?
Yeah, thank you. That's a really good point. We actually, so the United States has a scientific registry of transplant recipients, and it has full data on all of every patient who undergoes a kidney transplant. And it's a remarkable database that I use for a lot of other studies. And we've actually in our group talked about ways to link, and is this something that would be of utility? And is this something we should be focusing on? Because there's a lot more granular data about what happens kind of before the transplant and in people who don't have COVID-19, because as I think everybody is aware, we have struggled with our control group to some extent, because my interest is in sex and gender. And because our control group is matched based on sex, it makes it difficult to do comparisons and look at kind of sex-based risk. But in the SRTR, we could use a COVID negative control group and look at differences by sex. And so we have talked about it, but we haven't proposed a study that would go to the next step just yet.
Great. Yeah, no, that would be exciting. And I think technically should be doable. I see Ken is on. So anyway, so we're thinking about it. Well, thank you. This is a really great talk. So Jing Sun, I think it's you're up. So if you could share screens and association between immune dysfunction and post-SARS-CoV-2 vaccination breakthrough infections. You're able to share?
Yes. Let me.
Great, thank you.
Make sure. Is this the big screen?
Yeah, it's good. That's good.
All right, thank you so much for the introduction. So today I'm going to present our newly published study in JAMA Internal Medicine on the association between immune dysfunction and COVID-19 breakthrough infection following vaccination in the US. So first of all, I'd like to just provide a bit of context on the issue we face. So the rapid development and implementation of the COVID-19 vaccine has been shown to be highly effective against COVID-19 infection and transmission. but real-world data on the effectiveness of the vaccine among patients with immune dysfunction is still pretty limited. And additionally, no previous study identified the rates and risk of breakthrough infection in different time periods with different strain of variants of the virus circulating in the US. And here is the overview of our study. I'll provide more background later. And as we are trying to tackle this issue I just mentioned, we have initiated a collaboration between the ISC domain team, including HIV, solid organ transplant, rheumatic disease, multiple sclerosis subdomain team, as well as the vaccine effectiveness domain team to answer this question using the N3C data. So the primary research question is to determine the rates and risks of breakthrough infection after COVID-19 breakthrough after COVID-19 vaccination during different period of time. And the duration of the project, we started the project July 1st, 2021, and submit our first draft to the journal on July 28th, and continue to work with revision and such up to the October and November. And we use both level 2 and level 3 data for this project. And here's the background. Since the FDA approved the first COVID-19 vaccine to general use back in December 2020, COVID-19 vaccine has shown to be highly effective and safe in the general population in both the randomized control trial and real world data, as we know. And as shown in this figure published in New England Journal of Medicine, the Pfizer BioNTech vaccine show an over 90% efficacy in preventing COVID infection 7 days after the second dose. And real world data from Israel and UK before our publication has confirmed that the significant reduction on the COVID-19 infection among people received the vaccination. However, a large evidence gap exists for patients with immunodysfunction, because they were specifically largely excluded from most of the COVID-19 vaccine trial. And early on, several single-site study and immunogenicity study and cohort study have noted that patients with solid organ transplant have substantially lower immune response after the COVID-19 vaccination. And this figure here shows that the prevalence of anti-SARS-CoV-2 antibody after 4 weeks of the second dose of the mRNA vaccine in patients with solid organ transplant, and compared to an over 80% antibody detection and response among general population after the 2 doses of mRNA vaccine, the prevalence showing here among solid organ transplant patients is only ranging about 12 to 50%, so it's substantially lower. However, by the time of our study back in July 2021, the real-world data on the vaccine effectiveness among patients with immune dysfunction was still pretty scarce. So therefore, using the data from N3C, we started to compare the incident rate and rate ratio of COVID-19 breakthrough infection among people with and without immune dysfunction. This flowchart demonstrated our sample selection procedure for the current project. We used the data from N3C data release number 46, and we excluded patient based on our data quality check, including excluding data from sites that have pre-shifted date prior to data submission to N3C, because we think the timing of vaccination and breakthrough infection is very critical. We also excluded patients that have missing data on some key variables, including demographics, and those have death records before, oops. Let me just go back there, okay. Including those with a death record that were before the COVID-19 diagnosis or vaccination, and the final selection in the analytical sample are a little bit over 600K here. And they including all patients who receive at least 1 dose of COVID-19 vaccination. And so here, After that, we have identified COVID-19 vaccination using the existing the prescription code, and then we specifically including 2 mRNA vaccines from both Pfizer and Moderna, and 1 viral vector vaccine from the Johnson & Johnson, and other vaccine, although it's very small number in our population. We define the full vaccination as completion of recommended dosing regimen at the time of our study, which is 2 doses of mRNA vaccine, or 1 dose of Johnson & Johnson vaccine, or 2 doses of other vaccine, including AstraZeneca. And partial vaccination are considered as only 1 dose of an mRNA vaccine or other vaccine. The breakthrough infection were defined as COVID-19 positive 14 days after vaccination. We follow the N3C COVID-19 diagnosis definition. Initially, we included patients with COVID-19 who had a positive result defined by real-time PCR antigen, antibody, and diagnostic condition. We soon realized a large amount of patients with immune dysfunction have actually actively seeking antibody testing as a confirmation of their immune response after their vaccination. Therefore, we excluding all of the antibody positive result after December 10, 2020, which is the date that FDA approved COVID-19 vaccination for general use in the United States. And the disease severity for the COVID-19 was defined using the EMR classification procedure and condition code. We identified the most severe event within the 45 days after the COVID-19 diagnosis, and combine these outcomes into outpatient visit only, inpatient hospitalization, or severe outcome, including invasive ventilation, ECMO, or death. And the diagnosis of pre-existing condition, including history of HIV infection, multiple sclerosis, rheumatoid arthritis, solid organ transplant, and bone marrow transplant, as well as other comorbidity conditions were identified from January 1st, 2018, up until either the date of breakthrough infection or the end of study observation for the non-breakthrough cases. So we use Poisson regression model to estimate incidence rate and incidence rate ratio of breakthrough infection in our sample. And we use the Kaplan-Meier cumulative incidence curve to demonstrate the time to breakthrough infection by immune dysfunction group. And by the time of the study, Delta variant has contributed to a majority of the breakthrough infection cases. Therefore, we stratify our follow-up time into pre and post Delta periods. Specifically, we use June 20, 2021, when CDC identified over 50% of the COVID cases in the United States were attributable to Delta variant. So this table presents the patient's characteristic of our study. All of the patients, we including received at least 1 dose of SARS-CoV-2 vaccination. 90% of them received an mRNA vaccine and completed all recommended doses. And the median age was 51 years. Over 50% were female, and we identified over 36,000, about 5.5% patients with immune dysfunction. And compared to people without immune dysfunction, solid organ transplant, bone marrow, and rheumatoid arthritis patients were older. HIV and solid organ transplant patients were more likely to be non-Hispanic Black, and people with immune dysfunction condition were more likely to have more than 3 or more comorbidity conditions. So of the 600,000 fully vaccinated person, we found that about nearly 23,000 had a breakthrough infection with a rate of 5 persons per 1,000 person month. And compared to partial vaccination, full vaccination reduced the risk of breakthrough infection by about 30%. And then breakthrough infection rates were substantially higher after June 20, 2021, when the Delta variant became the dominant strain. Older age, female sex, and higher number of comorbidity were significantly associated with a higher likelihood of breakthrough infection. And after full vaccination, people with immune dysfunction have higher rates of breakthrough infection compared to people without immune dysfunction. And this difference is more apparent after the Delta variant because the became the dominant strain. And the incidence rate of the breakthrough infection was 7.1 person per 1,000 person month for people without immune dysfunction versus over 9 person per 1,000 person month for people with HIV, 8.9 for multiple sclerosis, 9.3 for rheumatoid arthritis, 15.7 for the solid organ transplant, and 8.6 for bone marrow transplant per 1,000 person month, respectively. And the median time from the flu vaccination to breakthrough infection was 138 days in our sample. And as demonstrated in this figure, compared to patient without immune dysfunction, patient with immune dysfunction condition, especially patient with solid organ transplant, bone marrow transplant, and HIV, had a substantially faster time to breakthrough infection. This table shows more or less the same thing as we present the adjusted incidence rate ratio of breakthrough infection. In the model 1 here, we evaluate the effect of full or partial vaccination status before and after Delta period, demographic, and number of comorbidities on breakthrough infection risk. And in this second model here, we evaluate all of the covariates in model 1 and then additionally adjusted for individual immune dysfunction group. So as shown here, and as I alluded earlier, compared to people with immune compared to individual only completed partial vaccination, the flu vaccination associated with about 30% reduction in the breakthrough infection risk. And breakthrough infection risk went up about 3 times after the Delta period. And then we also observed that older age and comorbidity burden is significantly associated with high risk of breakthrough infection. And interestingly, in this second model here, after we adjust for these immune dysfunction group, we no longer see a significant association between the comorbidity burden and the breakthrough infection, which suggests that the immune dysfunction is really what is driving the association between the comorbidity burden and breakthrough infection. And we also see that people with HIV, solid organ transplant, and rheumatoid arthritis has a significant associated with a significantly higher risk of breakthrough infection through the adjusted model. So here we presented that vaccination also substantially reduced the risk of severe COVID-19 cases compared to over 2 million COVID-19 cases occurred prior to the vaccination, which we presented in the left panel for both of the figure. So we can see that the COVID-19 outcome within 45 days was less severe among the breakthrough infection cases on the right bars on both of the figure. Specifically, we can see that the severe hospitalization going from 21% to 14.8% in the pre-vaccinated cases compared to the post-vaccinated cases. And then in the immune dysfunction group, the effect of vaccination is pretty obvious as well. The inpatient cases was going from 35% to 20% in the immune dysfunction patient. And then we also see the severe cases, which is the mechanical ventilation, ECMO, and death cases, were going from 6% to 2% in the pre and post vaccination cases. So in summary, our study provides among one of the strongest real-world evidence to date that patients with immune dysfunction have substantially higher risk for developing COVID-19 breakthrough infection and have worse outcome compared to those without immune dysfunction. However, our data also shows that COVID-19 vaccine is significantly reduced the disease severity among patients with immune dysfunction. And then additionally, completion of all recommended doses of vaccination is crucial in preventing the breakthrough infection, regardless of patients' immune status. And these data strongly support some alternative vaccine strategy, including booster shot among people with immune dysfunction. And pending further research and data, people with immune dysfunction should continue to consider non-pharmaceutical prevention even after their full vaccination. So our study also has certain limitations. First, by the nature of EMR data, we have certain limitation to identify a pre-existing condition, including those people with immune dysfunction as well as other comorbidity condition. However, we do think that such misclassification could be non-differential in our vaccinated and non-vaccinated group. And then secondarily, the SARS-CoV-2 vaccination status we have was only captured through the EMR and of large academic medical centers. So that means we may not include all of the vaccination record that's outside of their hospital setting, such as pharmaceutical and mass vaccination site. However, this underrepresented is less likely to affect people with immune dysfunction because they are more likely to receive regular care and would not alter the comparison of the risk. And third, we did not evaluate the risk for breakthrough infection among people with all the immune dysfunction, namely the cancer and some of the other rheumatic disease. However, we did conduct sensitivity analysis excluding these people from our overall sample, and then the result is consistent with our primary evaluation. And so at last, I just want to acknowledge that the study was conducted with the data and to assess through the N3C data enclave. And then this research was not possible if without the support for the overall development and of the database and the organization, as well as the bioinformatic contribution throughout. And I also want to acknowledge my colleagues and collaborators in N3C immunocompromised and vaccination group, especially the co-senior authors, Rina Patel and Greg Kirk, as well as the data analysts and management, Chulu, Gerald and Amy here. Just kudos to their efforts throughout this process. And thank you so much for your attention.
Thank you, Jing. Jing, that was a really very interesting talk, and we have some good questions. So 2 questions regarding variance and time. So Thomas O'Brien asked, interesting analysis. Did you consider dividing time into 3 periods, pre-Delta, mixed, Delta, highly dominant? By dividing the data into 2 periods, you may have underestimated the higher rate of breakthrough with Delta. And Joy Amajir says, thank you for your presentation. Does the breakthrough analysis include the Omicron variant, or is it pre-Omicron? Also, were you able to assess breakthrough infection rates for pre-Delta as compared to Delta variants?
Yeah, so I think these are really great questions, and it's certainly, like vaccine effectiveness through different variant and strain, certainly a question many people want to ask. I think there is a few limitations. First off, it is certainly not the most refined way to look at vaccine effectiveness by different strain, because we don't have the precise data on the strains of variant. So all we can do is really trying to see the breakthrough infection rate throughout different time period. I think it is certainly interesting if we breaking it down to, we currently essentially doing basically pre-Delta and post-Delta, and then, certainly there is a mixed period of time, as Thomas has alluded to here. But, I do think the key of our project is mainly to look at the rate, risk and rate among people with immunodysfunction. And the factor of the Delta variant, pre-Delta and post-Delta, is more like a factor to control for during our analysis. So we do think it's pretty effective to helping us to stratify these study sample in different because the just the incidence rate are not the same in the 2 period of time. But certainly we have continued project from the vaccine effectiveness group. We'll specifically look at each refined calendar period time of vaccine effectiveness in the overall population.
No, thanks. And so several compliments on your work from Francis Weaver and Amy Olix. Rena Patel asked, could I ask a question about vaccination immunization records synchronization outside of N3C, since the percent vaccination is so low within N3C?
Yeah, that's definitely an issue here. I mean, well, as I say, this would be one of the limitations we have, and I don't have a way to present, whether or not the vaccination rate and to comment on which site. And all we can do is trying to capture those site has the most vaccination record by proportion with the size of the clinic, and trying to sort of in some way control for that under reporting in vaccination rate. But I'm sure there are still missing record. However, for the purpose of a current study, I do think our current sample is sufficient, because we're only looking at people, everybody has the vaccination. We're trying to see the vaccine effectiveness among those people we have record and documented their receiving vaccination. And I do think if we do want to pursue a study question to, vaccine rollout and prevalence of vaccination, that will run into more of that issue. But for now, I think it's a fair assessment from my perspective.
So I have sort of a question or comment, something to think about my own. So looking at your data, the solid organ transplant numbers are really different than the other types of immunosuppression, just in terms of magnitude of effect. And so one of the things that seemed kind of interesting is, so if you look at, say, RA, rheumatoid arthritis, where the degree of pharmacotherapy and biological intervention is probably, I mean, it's fair to say it's probably generally not as profound. And the nature of the intervention, kind of harking back to the last talk, in some cases might actually be helpful in terms of cytokine storms with people particularly high risk. I'm just wondering if you guys thought about doing a sort of dissection of diseases that involve some degree of, in some cases, immunotherapy, sort of distinct from solid organ transplant, which obviously is critical, but it's a somewhat different population.
Yeah, sure. I think these are excellent points, and it's actually, this related to some of the ongoing study we have been working. One is to working with Amanda on the solid organ transplant subdomain team to, classify, the level of immune suppression and the kind of immune suppressant drug that they use, and then trying to tease that part out. And also we've been working with the renal disease team to sort of looking in a more finer detail on those kind of question you just mentioned. Yeah, exactly. Yeah. Those are very important questions.
And this certainly seems like there huge potential for data linkage. I mean, the vaccination is sort of obvious. I mean, it's all, I'm sure the regulatory aspects are a nightmare, but there's certainly some states, such as New York, keep very compulsive records. So the linkage would be possible, assuming they let you do it. Other states maybe not as much. Where do things stand in terms of discussion about data linkage with vaccination?
I feel I'm not in position to answer the data linkage here, but maybe Amy can have, bringing some perspective on the bioinformatics side, in terms of the data linkage.
And I see Rina Patel actually raised essentially the same sort of question. I mean, obviously it's not a subtle question, and I know we could do it if we want to do it if we could. Okay, Amanda Vinson, in solid organ transplant, we consider MMF to be the greatest risk. So maybe other ISE groups who use MMF. I'm not sure if I quite. Amanda, can you
sorry,
talk?
I was just building on
right, because you're a panelist, so go ahead.
Sorry, I probably should put that in the question thing. I was just building on what you were saying before about SOT being like kind of much higher risk than other immunosuppressed groups. And in SOT, we really think that the driving problem is the MMF. And so a lot of, for example, lupus, some people use MMF, not everyone does, but you can look at other immunosuppressed groups that use MMF, building on your earlier comment.
Okay, interesting. Yeah. Okay, well, this is great. So do we have any other questions, comments? All right, well, I think we've got 1 minute to spare. I think we're right on time. Really great talks both, and really great discussion. And thanks everybody. This was really very valuable. Have a good week. Take care.
Thank you.
Thank you.
Thank you.